All right, hi everyone. I'm gonna get started because we're a little bit behind. All right, so I'm gonna be talking about cross-cultural end-of-life care. I want to give a really special thanks and shout out to Dr. Agenor and also to her family because they helped me look through a few subjects on this slide and gave their input and insights, which I found really valuable and definitely added a lot to this talk. And especially thanks to the social EM team as well, Dr. Sim, Dr. Forbach, Dr. Warshaw, Dr. Kindle, Dr. Christoph, and Dr. Lavender. And I'm Bing. All right, so what we're going to talk about is why it's important to have this talk. A little bit about collectivism and collectivist cultures, a little bit about issues in pain management, some issues in traditional healing, some misunderstandings regarding like hospice and palliative care, and some tools on how to perform a cultural assessment. So this is a quote that I encountered looking through some palliative care journals. I think this one is from Palliative Care Nursing Journal. And I really like this quote and I wanted to put it up front. Dr. Agenor's parents actually helped provide a more direct translation of this proverb. Basically, the direct translation they said is that the happenings of man is a mystery. And the idea is that you might see a person and think that you know them or want to know them and think you might know them because you want to know them, but really you don't know anything about them. Their own experiences and their life is a mystery to you. You can't know about the background and where they're coming from. And the reason why I really felt like I wanted to display this quote up front is because I think it's a great illustration of the concept of each individual's uniqueness. And in this talk, I'll basically be inevitably discussing some generalizations about certain cultural beliefs. And I want to make it clear that the point of this talk isn't to tell us what we should or should not expect from certain patients or what exactly to do when caring for certain patients. What's most important, as we all know and we're all taught, is that to still communicate clearly with each patient and their family and respect their own unique goals and wishes because they're all coming from different unique places. I did a little bit of legal background. This act is basically a requirement of any healthcare facility that receives like Medicaid or Medicare funding, where patients have to be informed of their rights to make decisions regarding their care and to periodically assess for advanced directives like we do when we ask them about their preferences when they become admitted, and also to not discriminate against persons who have executed an advanced directive. And I feel like although technically we learn, like, I feel like for us, we all know like not to discriminate against people and still give them a good level of care if they have like a DNR or DNI. But I have encountered other staff that kind of think like, oh, they have a DNR, we shouldn't take care of them anymore. Like why are you putting all this effort? And I feel like that's something that as a culture in the medical field still needs to be worked on so that patients don't have the misconceptions that they end up having a lot of the time. So why is cultural competency in this area important? So these are just screenshots from two different papers. I think one was pre-COVID and one post-COVID regarding palliative care perceptions and experiences in ethnic minorities in the US. And basically both found that typically patients from ethnic minorities were more likely to be referred to palliative care late in their disease course. They were less likely to die at home, even if they wished to die at home. They usually had fewer home care visits, even if they were in a palliative care program. And one of the studies found that patients with end-stage cancer were more likely to have numerous hospital stays and ED visits compared to patients from ethnic majorities or from higher socioeconomic groups. And they also found that patients from ethnic minorities in the US tended to opt for aggressive care and aggressive treatments compared to patients from higher socioeconomic groups. This is a plug for paper by our own Dr. Muchatada and Dr. Camacho and SAEM. I'm sure we all know that immigrant communities have been more affected heavily by the pandemic and that they're also more vulnerable both to misinformation and because they have received they had a history of poor treatment from the medical community regarding because of things that happened in the past between the medical community and those communities. So naturally there's more vulnerability to misinformation and mistrust. So now I'm going to go into talking about some different perspectives and how they might affect our patient care and our conversations. So this is a quote also from the paper from earlier from the Nursing Palliative Care Journal. And basically in this journal, they interviewed several family members of patients that had eventually entered palliative care about their experiences. And all of the persons interviewed were from the local Haitian community. And this is a daughter that was interviewed who had a mother dying of glioblastoma. And she reported that she felt very torn between lots of healthcare providers wanting to make quick decisions and between the larger family that she's a part of that wanted more time to be able to process what's going on and be involved in the process. And because she was the spokesperson of the family, she felt that she was kind of being pressured to make these decisions quickly, whereas more traditionally, there's usually time for the larger family group to get together and make decisions as a family. So what they found is many times in a Haitian family, they'll designate an individual to be the spokesperson, but it's important to understand that that individual might not be necessarily the person that's making the decisions or the healthcare proxy. This might be the person that's just selected by the family because they either have a better grasp of English or a better grasp of the healthcare system. So it's important always to make it clear who is actually the person making decisions in these cases. So going off of that last quote, basically, I feel in our medical education, we mostly learn about approaching end-of-life conversations and goals of care discussions from our perspectives, which comes from a reflection of American and traditional Western values, such as autonomy and individualism. We're taught to ask patients, like, what do you find the most important? What do you want to do? So it's always important to reflect on what are our own values and how we might project those onto patients. I know I have experiences where I've asked the patient to make a decision regarding even a medication choice or consent for a blood transfusion or invasive procedure. And instead of giving an answer, even though they're awake and alert and able to do so, they say, oh, can I ask this family member, or can I ask my parent or a spouse, or can you call this person that's in my family, and they'll decide for me. And at first I thought this is like really annoying because I'm gonna have to take more time away to go to the phone and call this person, and they're gonna pick up, and then it's gonna be a delay in their care, and I have other patients to take care of. But after reading about these different perspectives, it's kind of helped me acknowledge and validate why a patient might feel this way and feel that these decisions aren't just their own, but are a part of a larger collectivist culture. For example, just like the daughter that was in the previous slide on that quote, where she felt that other family members were distraught because they were basically feeling alienated and left out of conversations because they couldn't understand English as well as she could. She felt that she made the right decisions in the end and her mother was able to pass away comfortably, but that other family members kind of felt sad and felt left out and weren't able to mourn in as calm a fashion as she was able to. One way to address this is to not only clarify if that spokesperson is indeed the next of kin, but also to ask them if there's someone else that the patient would like to be involved in the conversation. If it's possible, you can talk with that person present and with a translator, but sometimes if you're communicating just over the phone call, especially now during COVID when patients aren't always able to visit, you can then give that spokesperson time to talk to the other family members and then get back to you if it's possible, if the time is available. So this is a rather chaotic graphic that was from a paper focusing on Haitian communities and how they deal with end-of-life care. It's basically an illustration of the process and of the complex emotions that families can go through when facing the end of life of a loved one. When they're facing these issues, they're not only thinking of their own feelings and the family members' feelings, but they also have to think about the larger community that they're a part of and that they'll have to return to after these decisions are made. A person that's making decisions for an incapacitated patient may even feel a lot of guilt or anxiety, feeling like they have to make these decisions. So it's really important as a healthcare provider to remind the patients that they aren't the person that's necessarily making these decisions themselves, but they're rather the person that is helping an incapacitated patient communicate what they would have wanted if they were able to make that decision for themselves, and that their role is to help the patient maintain dignity and autonomy in this situation. So we talked a bit about collectivist cultures and how that might affect the way that patients process grieving and process end-of-life care. Um, Sometimes this can go into even more extremes, where a family might expect information to be given not to the patient first, but to the family members first, and that the family members should be making those decisions. We tend to see this less in our patient population, I think, but it can be common in many Asian, Pacific Islander, or even Middle Eastern communities. For example, in my family, I'm not really close to my family in China, but I was told that my uncle that was in China was dying of cancer, and that they were like, oh yeah, of course we didn't tell him anything, and he doesn't know that he has cancer, that he's dying, but don't worry, we're taking care of it. We're making all the decisions. And at that time I was in medical school, and I thought this was completely wild. Like, what are they? This is not ethical. Like, you can't just not tell them what's going on. But hearing more about what's going on, it sounds like that's what he would have wanted and what the family expected from that culture. That's what the healthcare system expects in that culture. So it's normalized, and they apparently remain in good spirits, and everything went pretty well for them. So a family might even expect information to be given to them first rather than to the patient. According to one review that I read on palliative care, there are many Korean Americans and Mexican Americans that reported being more likely to consider their family as their decision maker rather than themselves. And there's also beliefs regarding filial piety in many Asian cultures that require family members to take on this burden of making those decisions, because they feel that the elderly patient or the sick patient shouldn't have to take on such mental burdens. They should just be the sick person that's taken care of, and the family should be taking on that role of making decisions for them. One way to address this preference in an ethical way is to ask the patient first, before telling them about the diagnosis or prognosis, if they would like to know about difficult news and who they would prefer to make those decisions, whether they'd like to know about it and make those decisions themselves, or if they'd rather you tell somebody else, like a close family member or friend, to make those decisions for them. And then going off of my last story, in some cultures, talking openly about death or dying is just simply not acceptable. It's considered disrespectful to tell someone of their prognosis. It can be a cause of loss of hope for the patient. It can be a sign of disrespect and bad luck. I think in my extended family, it's very similar, where they said that, it'd be so rude to tell him that he's dying. Like, it would just be wrong. Like, why would we do that? In many Southeastern Asian families as well, the family member is traditionally not told about a terminal illness because it's thought that that's very disrespectful to the ancestor, and can kind of affect like the spiritual realm as well. And even for some Somalis and for some Muslims, I read that talking about death to the patient as a provider is considered taboo and bad form, and that a religious leader sometimes needs to be involved to facilitate that conversation rather than just you and the patient alone. Some other aspects of cross-cultural care can be that perceptions of the physician's status can be different in other cultures compared to our own. For example, we might be used to patients taking initiative and being able to say, oh, I don't want that, I want this, or speaking up when they feel that something isn't right. But in many cultures, people might feel that's not acceptable and disrespectful, and that if they ask a question or are uncomfortable with a situation, that they shouldn't speak up. So it can be important to normalize shared decision-making and to normalize a patient asking questions and asking them if they have any concerns. In Shoreville had experiences where we asked somebody to get involved in shared decision-making, and they just look really bewildered, or even look at you like you're crazy, like, do you know what you're doing, since you're asking me what's going on? But it's important to just say, like, hey, in our hospital, we're here, we like to ask patients what they want, because many times different treatments aren't necessarily much better than one another, but it depends on your preference and what you prefer. And that's especially important when dealing with palliative care and end-of-life care. Another thing that culture can affect is a patient's response to pain and their experience of symptoms. In some cultures, they value a very indirect communication style, which means that publicly displaying emotions or confrontation is considered not acceptable. So they might just wait and kind of wait in silence and never get their PRN pain medications because they never ask for it. So sometimes it can be important to either put those medications as scheduled, or have you take more initiative and ask the patient if they want something for their symptoms. Cultural perceptions regarding the experience of symptoms can also affect overall care and long-term health. For example, reading about some traditional Haitian medicine, there's a perception that disease is driven by the experience of symptoms, which means that when you don't experience symptoms, that means you don't really have a disease, which is why we often see patients that come in seeking medical care if they feel that their headache or their dizziness is caused by high blood pressure, and they'll take medications until their symptoms resolve, but then stop taking it when they feel like they're better. And this isn't because of disrespect or because they're just being non-compliant. It's kind of a misunderstanding of what disease processes are and a misunderstanding about the chronicity of diseases. Of course, religion and faith can be very important as well. These are just some, this is a number for downstate and then numbers for county. There's supposed to be a chaplain available 24 hours at either number through the page operator. I think every time I've tried to call for one, the families decided they wanted to leave before they could make it down to the ED. But there should be a rabbi, Protestant and Catholic priest available at county, and a chaplain at downstate, not sure what religion. I'm sure, as we all are all aware, for many cultures, prayer and religious ceremonies are very important as coping strategies. And there might be some specific like rituals and tasks that a patient or family might ask for, but that you might ask a family if they would prefer. For example, for some Muslims, reciting the words of the Quran as they are dying can be very important, as well as taking the patient's bed and facing it in the direction of Mecca. Similarly, in some Buddhist cultures, they want the last words for the patient to hear is either Buddhist scriptures, one of the names of Buddha. And then there's also, of course, last rites that are traditionally given by a religious leader in Catholicism and Judaism. Alternate medicine practices are often also used simultaneously with Western medicine, often for symptoms of the disease like the pain, nausea, vomiting, shortness of breath. Some of these remedies do inhibit some of the like CYP 450, whatever inhibitors, and can affect other medications that they're on. So sometimes it's important to look those up for toxicologic effects. And then going beyond herbal remedies, there's also a use for traditional healing and rituals. This is a picture of a Mambo traditional priestess from Haiti. And basically, I read some case reports of ritual practices with these traditional healing leaders that can help patients both alleviate chronic pain and also kind of act as a conduit for therapy and processing their emotions and feeling that they're getting a chance to reflect on their experiences and have a sense of connection and validation with the religious leader. And the point is that basically it normalizes their experiences, it helps them feel their feelings while also avoiding the stigma of going through like traditional psychotherapy and thinking there's something mentally wrong with them. There's a lot of miscommunication, lack of experience, and mistrust, oftentimes when it comes to patients, especially from ethnic minorities, and their understanding of what hospice and palliative care really means as well. For example, in some of the papers that I was reading, there were anecdotal cases where palliative care consultants were saying that there's patients that say, oh, if I sign an advance directive, that means I'm signing my house over to the hospital, right? Or signing an advance directive is the same as a legal document where they're signing over their belongings. And this is related more to like burial and funeral arrangements than it is to their experiences. It's a very common misconception amongst many non-medical communities that hospice is basically euthanasia or physician-assisted suicide, that it means giving up on the patient. And that's also a last resort. And going back to the role of religion in these cases, in many religions, life is considered sacred by all means, especially in lots of like Hispanic Christian communities or African-American Christian communities. And people from those communities are a lot less likely to want to withdraw life-sustaining care. And that can come from a background in religious beliefs as well. So I'm going to talk about some tools in obtaining what's a cultural assessment and looking at basically a systemic way of gathering and documenting information about the patient's cultural beliefs, meanings, values, and patterns. I meant to mention earlier when I talked about the objectives of this talk, but forgot to, that this isn't a talk on how to do a goals of care discussion, because that's a whole nother talk. And this isn't a talk on what palliative care really is, because that's also another talk that's going to happen later this year. But basically, I'm just going to talk a little bit about some tools where that have been developed to help you gain more of a cultural understanding about patients and how they are perceiving and experiencing their illness. So one model I'm going to talk about is the Kleinman and Campbell's patient explanatory model. Looking through several different models, this was like the most straightforward. Other ones were like, oh, look at this factor and then this other factor and then a web from there. But this one's just 8 questions and another 4 questions. They're developed by this psychiatrist and anthropologist, Arthur Kleinman. He basically wrote that he thought that doctors these days perceive patients as a body experiencing biological symptoms rather than as a full person that's experiencing the course of their illness. From talking to patients, he found that health and illness are not just the end results of biology and behavior, but that it's usually more complex and deeply interconnected with their lives. He basically developed this list of questions as a tool to help doctors who didn't have as much time to spend with each patient to assess their beliefs and perspectives. And looking at some of these questions, it really does start from the beginning and start from scratch, like making no assumptions of that the patient understands what disease comes from or that they're coming from the same place as you. And I appreciate that, that you're asking, like, what do you think has caused your illness and why do you think it started like that? Basically, you might find some surprising answers about why patients feel, or what patients think are the cause of these things compared to what you think or what you would assume. And then these are just additional questions to ask regarding how their family thinks as well, because like I said, for many patients, the family unit and the larger cultural unit is also very important in their experience. So even though I said this isn't a talk on giving difficult news or making a goals of care discussion, I just want to touch really briefly on this acronym on how to like set up talking to a patient about difficult news. So first, you want to kind of set up the interview, set up the fact that you're giving difficult news through either body language, positioning of the patient, have them either sit down on a bed or on a chair, and positioning your body in a way that's compassionate, either being eye level or even kneeling down lower than the patient, rather than towering above them if possible. And then the next step, after kind of setting up these expectations that there's going to be a difficult discussion, is assessing what the patient or the family member already knows about what's going on, inviting them to say like, hey, what do you think is going on? Or what do you already know about the situation? And then step 3, obtaining the invitation of the patient. This again makes sense in the context of knowing that some patients might not want to know about their prognosis, or rather somebody else be the decision maker. And then step 4 and 5, giving the knowledge and addressing the emotions are kind of intermixed. And I feel like many times in the first conversation, you don't necessarily get past this step with patients understanding what exactly is going on. They might need more time to process. And then step 6, giving them the next steps, a strategy and a summary of what's going on. And often you have to go back and kind of give the knowledge again and address their emotions again, and kind of go back and forth there. And then a last informational thing I want to talk about. I sent this PDF, I think yesterday. It's basically in Haitian Creole, and also I think some of it's translated in English as well. A document that can help patients and their families kind of go through and start thinking about their goals of care, especially with a poor prognosis or at end of life. And there's a few pages that kind of ask about what a patient would like in terms of aggressive care, intubation, those kinds of things. And it documents it in a very like direct way and explains it pretty well. And then there's another few questions that kind of talk about what if they would prefer certain comforting things done, what things would comfort them, like music or massages, like that kind of thing. It's a pretty long document, so not something you would go over with a patient in person, the way we would go through like a advanced directive or DNR, DNI document, but maybe something that can offer patients to take home with them or show their family or just think about. I think in some states, including New York, if you get a notarized, it counts as an advanced directive. But I don't know if in our hospital system where in most hospital systems if they accept it, but it can help because it explains the process pretty clearly and is also translated in many languages. The one I sent is only in Creole because that's the only one I could get. But it could be a helpful way to introduce patients to the subject. And then in conclusion, we talked a little bit about collectivism, about deficit taboo, the way different perceptions of pain can affect care, religion, traditional healing, and some different perspectives of palliative care, and an introduction to Kleinman's model of cultural assessment. And this is my cats, and this is a lot of references. Any questions? I think I'm about at the end of my time. Yeah.
So that was very good. It just reminds me of so simple. William Osler once said, "Don't just treat the disease, treat the patient with the disease." Very important. And the slight correction. That's Rabbi Leder's office number that you had there. Unfortunately, we lost Rabbi Leder about a year ago to COVID. So you can still call that number. That's his office. He passed away. Wonderful, wonderful man who loved emergency medicine. He passed. That's the same one.
It's really tough. Anyone else?
Yeah, I want to just say amazing. Can you hear me? Brewster.
Oh, hi. I can sort of hear you.
Yeah, well, very well done. I think with a community that is more than 80% Afro-Caribbean and Afro-American, understanding what the culture embodies is so important. And understanding some of the obstacles that, that we embark every day with treating our patients. And they're not really obstacles, I guess, a better understanding of why why people think the way they do. I think the best way to understand it is really getting, like you're doing, exposing everyone to the culture. And that just doesn't include just the food, right? That includes religion, that includes history, because there is a very big difference between the Afro-Caribbean culture and the African-American culture and how they perceive healthcare. And that spans back, I know for the African-American, back to 1932, all the way to the 1970s with the Tuskegee trial, which a lot of Afro-Caribbeans really don't embrace, but they have their own history, depending if they're from Trinidad or from Barbados. So I think the residents here have an amazing experience of seeing how different, although they might have the same skin tone, how different these amazing patients that we have embark on, or how they see healthcare. And if we don't have these conversations that you've so well done, like if we don't have these conversations, and if we're not out in the community doing outreach programs, going to the churches, understanding what is really behind all of this, then we're really not doing the full justice of being healthcare providers in this community. So it is complex. It does entail a lot of conversation, and it does entail bringing people from the culture into the conversation and to really understand the complexity. I'm Afro-Caribbean and African-American because my mom and dad are from different places. I have exposure to both, as well as many of our residents. And it's complex for me. So I really think that I sympathize with some of the residents who don't understand and who haven't been raised in this community to really understand why are patients saying no to certain things? Why are they asking you to speak to someone else? Why are they not jumping at the option of a new medication? We had a sad case where just due to the patient not understanding what was being offered, the patient chose death. And we don't want that to happen, right? So by you having these types of conversations, and we have more of these, and with humility, we can get through this and treat our patients the way that they deserve. So very well done. I hope you guys could hear me. I don't know if you could.
Thank you, Dr. Brewster.
Thank you,